and you can write your questions. Please write your questions in the chat box, and we will ask for on in the discussion time. If you are too shy to write in English, please write in Indonesian, and we will help you. I guess that would be all. Prof. Langer, please kindly start your presentation. Thank you.
Thank you so much, Francisca and Emiliana, who I also see on my screen on the right. I just want to make sure that you don't want me to be following the chat box. You are going to follow the chat box and then ask me the questions later. Is that correct?
Yes. We will give you the question.
Okay. And everybody can see the screen?
Yes.
Okay. So so today I'm going to talk about Hirschsprung disease, and I'm going to start with just a bit of an overview of the etiology and some of the genetics, but not a lot of detail about that, because what I want to do is focus more on the clinical management of children with Hirschsprung disease. So we'll talk about the surgery and some of the controversies in how the operation should be done. And then I'll spend some time at the end talking about the problems that these children can have after their surgery and how to approach those problems and how to try and understand them and deal with them. And then there should be time at the end for comments and questions. I find when I speak to a group of experienced surgeons from places that I don't come from, I usually learn more than I teach. So I'm looking forward to hearing your comments and your questions. As you all know, Hirschsprung disease is a condition where the ganglion cells are missing in the distal bowel, usually in the colon, but as you know, sometimes can involve the entire colon. And if this is in this diagram, the distal bowel where the ganglion cells are missing is relatively small and contracted with no peristalsis, and you end up with dilated proximal bowel. And then the area between them is the transition zone, where there are some ganglion cells present, but they're not the normal amount. And we think that Hirschsprung disease is caused by failure of complete migration of the neural crest cells, which start near the vagus, so in the caudal, in the cranial part of the embryo, and then migrate. Neural crest cells migrate to multiple places, but the ones that form ganglion cells migrate to the bowel and then migrate down the bowel from proximal to distal until they reach the bottom. So why are the ganglion cells not there in children with Hirschsprung's disease? Well, there are two theories. The first one is that they don't ever get to the bottom. And that is probably because they differentiate from neural crest cells to ganglion cells too soon. And a neural crest cell knows how to migrate, but a ganglion cell is too mature and has differentiated to the point where it no longer knows how to migrate. It becomes a ganglion cell. And so if the process of differentiation into ganglion cells happens too soon, then the ganglion cells will not get all the way to the bottom. But there's also a theory that in some cases they may actually reach the bottom of the intestinal tract, but for some reason they don't survive there. And that's probably because the microenvironment, the other cells around them are hostile, and those ganglion cells get there, but then they disappear. And it's probably, I think one of the things we now understand is that Hirschsprung's disease is not a single disease. It's a phenotype for a variety of different conditions that may be caused by different genes and may have a different etiology, but they all, to us, look the same because they resulted in lack of ganglion cells at the distal part of the intestine. But I think this old idea that Hirschsprung's disease is one disease is probably incorrect. And the fact that there are so many different ways that Hirschsprung's can present, and such a variety in how severe the Hirschsprung's disease is, supports this idea that that it's really a whole group of conditions that are caused by different things, that we're just not smart enough to understand all those different processes. We do know that Hirschsprung's is a genetic disease, and this has been suspected for a long time because there's a family history in a significant number of patients. And also, we know that Hirschsprung's is associated with other familial or chromosomal diseases. The most common one, of course, is trisomy 21. But there are many other diseases that are known to be chromosomal or familial, where Hirschsprung's disease is part of it. And now, over the past 20 or so years, there have been quite a few genes that have been specifically identified where mutation in that gene is known to cause Hirschsprung's disease. The most common one is RET, but the endothelin system is also well known to cause Hirschsprung's disease. And these two genes, RET and endothelin, are very different. They're on different chromosomes, they have different functions. And this supports what I was saying before, that Hirschsprung's disease is not a single condition, a single disease. It's a phenotype, a clinical presentation that might be caused by a variety of different genes. The genetics of Hirschsprung's disease is also very complicated. You can have multiple people in the same family who have exactly the same gene mutation, but one of them might not even have Hirschsprung's disease, one of them might have total colonic Hirschsprung's disease, and one of them might have just a rectosigmoid transition zone. And it's not clear to the geneticists why the same mutation might present in such different ways. And that tells us that there are a lot of other factors that determine whether a child has Hirschsprung's or not, and what the severity is, not just the gene mutation. There are many other factors, and there's a lot of research now being done to try and identify what those other factors are. So now I'm going to move away from that and into clinical issues in Hirschsprung's disease. And just to go over, I know I'm speaking to pediatric surgeons, so much of what I'm going to say is something you already know, but I want to try and put it into a context. We make the diagnosis of Hirschsprung's, we suspect the diagnosis based on the history and the physical examination. Many of these children, 95% of them, will have failed to pass meconium in the first 24 to 48 hours, although not all of them. So it is possible to have Hirschsprung's disease if the child has passed meconium. And it's also, of course, possible for a child to not pass meconium in the first 48 hours and not have Hirschsprung's disease. But that certainly makes it suspicious. Many of these children, about half, will present with a neonatal bowel obstruction. We do a workup, which we'll talk about, and make the diagnosis quite early on. But some of them will present with chronic constipation, so they will do okay in the neonatal period. And then as they get older, they develop severe chronic constipation, usually with other things like failure to thrive or a big distended abdomen. And some of them will present primarily with enterocolitis. And these kids will develop all of the signs of enterocolitis, including diarrhea. And sometimes that makes it difficult to suspect Hirschsprung's because we don't think of children with Hirschsprungs having diarrhea. So you have to keep that in the back of your mind. Most people will do a contrast enema if they suspect Hirschsprung's disease. And I say contrast enema and not barium enema because certainly in our center we discourage the use of barium in small children. So we use water-soluble contrast. And the typical appearance of Hirschsprung's disease is here, where you have a distal bowel that is smaller. There's a lot of spasm in this distal intestine. This is the aganglionic intestine. And then the proximal bowel is dilated, and this is the normally innervated bowel. And there's a transition zone here that is pretty clear in this contrast enema. It is important to remember that in newborns, about 10% of children with Hirschsprung's will not have an identified transition zone on their contrast enema. So it's possible to miss Hirschsprung's disease if you are just looking at a contrast enema. So I think it's really important if you have the capability to confirm the diagnosis with a rectal biopsy in children with suspected Hirschsprung's. Another thing we sometimes use for the diagnosis is anorectal manometry. And this is where we place a pressure sensor in the anal sphincter. We're measuring the internal anal sphincter. And then you blow up a balloon in the rectum and look for the relaxation of the internal sphincter. And this is the normal reflex. So this is the balloon, this is the sphincter. When you blow up the balloon, you see a reflex relaxation of the sphincter. And that's normal. In children with Hirschsprung's disease, you blow up the balloon and you don't see that relaxation response. In fact, sometimes you see a bit of an increase in sphincter pressure. We don't use this for newborns with Hirschsprung's disease because technically it's difficult to do. Some centers have described anorectal manometry in newborns, but it's difficult to do. But I find it's particularly useful in older children who present with severe constipation and you want to rule out Hirschsprung's disease. If you do anorectal manometry and you find a normal rectoanal inhibitory reflex, if it looks like this, then that essentially rules out Hirschsprung's disease. And you therefore don't need to take that 5-year-old or 10-year-old or however old the child is and put them to sleep and do a rectal biopsy under general anesthetic. You can rule out Hirschsprung's based on the anorectal manometry. If you don't see a rectoanal inhibitory reflex, that doesn't mean it is Hirschsprung's, because you can have a false negative on the anorectal manometry, and so therefore you need to go ahead and do your rectal biopsy. The rectal biopsy is really the gold standard for the diagnosis. In smaller children, and in my experience, around less than 1 year of age, the suction biopsy technique is quite easy and safe, doesn't require a general anesthetic, and will usually, with a good pathologist, will usually give you an answer. In older children, the mucosa is too thick and the suction biopsy often doesn't get any of the submucosa. And of course, you need to see the submucosa if you want to rule out Hirschsprung's disease, because that's where the ganglion cells should be. So this is an example of a full thickness biopsy. This is the myenteric plexus, the plexus between the two muscle layers, and there are no ganglion cells there. And then this is the other finding that the pathologists usually look for, and that is hypertrophic nerve trunks. And these are the nerves that are coming into the bowel from outside the bowel. And I like to think of it that the nerve trunks come in looking for ganglion cells to talk to. They don't find any ganglion cells, so they just become bigger and bigger. And you are usually going to see these hypertrophic nerve trunks in a child with Hirschsprung disease associated with lack of ganglion cells. Now, many pathologists have used other techniques. This is the cholinesterase stain, where normally there should be very little staining with cholinesterase, and in Hirschsprung's disease, you see a lot of extra staining, especially in the submucosa, and that is an additional finding, in addition to lack of ganglion cells, that the pathologists will look for. Cholinesterase staining can be difficult technically to interpret, so a more recent technique that's being used is the calretinin staining, which is an immunohistochemistry stain. And normally it should look like this. This is the pattern of calretinin. In Hirschsprung's disease, that's completely missing. So our pathologists in Toronto, they use H&E and cholinesterase and calretinin, but I know many pathologists are switching from cholinesterase to calretinin. And of course, there are many pathologists who don't use either of these other stains. They just use H&E, looking for presence or absence of ganglion cells and nerve hypertrophy. So now I'll talk about how do we manage a patient. We've now suspected the diagnosis, and we've done a rectal biopsy, and we've shown that it is Hirschsprung's disease. I don't know if you can read this. It says, right about here is where we'll be removing your wallet. And in the United States, that's a funnier joke than it is in Canada, because in Canada we have universal health care. As most of you know, there are three main kinds of operations that are done for Hirschsprung's disease. The original one to be described was the Swenson. In these diagrams, the solid lines are the normal bowel, and the wavy lines, like this, are the bowel that is aganglionic. So in the Swenson, the rectum is completely removed, and an end-to-end anastomosis is done between normal bowel and the aganglionic anal sphincter. In the Soave, the muscle of the aganglionic bowel is left behind, but the mucosa is stripped out, the mucosa is removed, and the normal bowel is brought down through this cuff, what we call a Soave cuff of muscle, and anastomosed just above the sphincter. The reason the Soave was developed was because in the early days, there was a lot of concern about damaging pelvic nerves and vessels, doing a dissection deep in the pelvis of a small baby. The Duhamel operation was designed because the plane behind the aganglionic rectum is a relatively avascular plane, and so that plane is developed. The normal bowel is brought down and anastomosed end to the back of the aganglionic rectum, and then the two walls are joined, nowadays usually with a surgical stapler, to create a single lumen at the bottom where the anterior part is aganglionic and the posterior part has normal nerve cells. There is no good evidence that any one of these operations is better than any of the others. The operation that most surgeons do is the one that they were trained to do and that they do frequently, so they become very good at it. And there's a lot of regional variation as well. I know, for example, in the United Kingdom, in Great Britain, many people are doing the Duhamel operation, whereas in North America, we see more of the Swenson and Soave operations. I'm not sure what's being done in Indonesia. I know most of the surgeons that I know there are doing a transanal, either Swenson or Soave. But I'll talk more about the transanal approach in a few minutes. So there's been an evolution in pull-through surgery that I've witnessed because I'm now old enough to have been trained in the days when every baby with Hirschsprung's disease got a stoma, a colostomy usually, although if it was long segment disease, it would be perhaps an ileostomy. But every baby got a stoma. And then later on, they had a pull-through done, and the pull-through was always done through a laparotomy. And then the question came up, and this happened in around the early 1980s and through the 1980s, which is when I was training. The question came up, is a routine colostomy actually necessary in every baby? And the reason colostomies became part of the routine was because in the early days, this is a picture from Dr. Gross's textbook of pediatric surgery, many children presented very late with severe distension and severe enterocolitis in many cases. And a colostomy was a life-saving operation. But nowadays, and I'm sure in many parts of Indonesia, the children still look like the top picture. And I have to say that even in Canada, we sometimes see children who present to us late with malnutrition and a big belly like that. But that's not very common anymore, at least not in North America. And most babies are diagnosed early on, and they're not malnourished, and they're in pretty good shape. So it really doesn't make sense that they would all need a colostomy. This is a paper that we wrote in the mid-1990s after we had switched over from doing a routine colostomy to doing a selective colostomy. And in the group I worked with at that time in St. Louis, there were 2 surgeons that did one-stage pull-throughs and 2 surgeons who were still doing routine colostomies. So that gave us the opportunity to study this. But what we found was that the complication rate from the pull-through itself was about the same if we did it in 1 stage or in 2 stages. But the children who had a preliminary colostomy routinely had additional complications that were related to the stoma itself. And there were many other papers at this time that showed that there was no need for routine colostomy in these kids. So the standard became a 1-stage pull-through in most cases, but there still are indications for a stoma. The first one is if the child presents with severe enterocolitis that you can't settle down fairly easily with antibiotics and irrigations. There are some children who present with cecal perforation because of the distal obstruction from the Hirschsprungs. The cecum becomes very distended and can perforate. So a baby who presents with cecal perforation and turns out to have Hirschsprungs, that child, we would normally give that child an ileostomy, repair the cecal perforation, and then go back later and do the pull-through. This is another one which I think might be more common in Indonesia than it is in Canada, where you may not have adequate support from a pathologist to identify the transition zone in a 1-stage procedure, to accurately identify where the ganglion cells are to do a 1-stage operation. If you don't have adequate pathology support, then sometimes it's best just to do a colostomy, wait for permanent sections, either by your own pathologist or even by a pathologist in a bigger center, and then do the pull-through later. And this is an example from my own practice where this child was diagnosed as total colonic Hirschsprung's disease based on frozen sections. The surgeon did an ileostomy and thankfully did not remove the colon. But when all the final pathology came back and was reviewed by the pathologist where I was, we found ganglion cells everywhere, and this child actually never had Hirschsprung's disease. And if a total colectomy had been done based on frozen sections, that would have been a very bad thing for this child. The other indication for a stoma, even nowadays, are children who present late and have a very dilated colon. And this is an example of that. This is a 3-year-old boy who presented with a big distended abdomen and a very large rectosigmoid. And after a colostomy, this child's bowel came down in size, and he could undergo a transanal pull-through without too much technical problem. So I will still do a stoma in a child with a late diagnosis. And I also do stomas in children with total colonic Hirschsprungs, but we're going to talk about that a little bit later. So the next thing that happened was in the 1990s, when laparoscopic surgery became more common in children, people started applying laparoscopic techniques, minimal access techniques, to pull-through surgery for Hirschsprungs. The first thing was laparoscopic, and then this transanal approach came from that. And the first one to describe a laparoscopic approach to Hirschsprungs was Keith Jorgensen, who at the time was in Birmingham, Alabama. And he would put the scope in, he would do his biopsy to identify the transition zone and the normal innervation. And then this is at the end of the pull-through. So he would do a transanal approach at the bottom and a laparoscopic approach from above, and then do his pull-through. And he and many of his colleagues published a fairly large series after they had started to do this operation. This was in 1999. And they showed a decrease in the hospital stay compared to the old open approach, with a similar complication rate. So this seemed like an excellent idea. And at that time, I was fairly early in my career, and I did a number of these laparoscopic pull-throughs, and I thought it was great, but I started to question whether the laparoscopic dissection from above was actually necessary, or whether we could potentially do the whole operation from below. And at the same time as that, this gentleman right here, who you mentioned earlier, Luis de la Torre, this is me at a much younger stage of my life. This was the Mexican Association of Pediatric Surgeons meeting. We were all working very hard, as you can see, at that meeting. But Luis also had the same idea, and the two of us, without even knowing each other or without knowing that we were both working on the same thing, both started doing a transanal approach to these pull-throughs. And I'm going to show you a quick video, if it works. Yeah, so this is the way I do a transanal pull-through. And I use a small umbilical incision to do my biopsy. And in order to identify the bowel, I put a Hager dilator in the anus and push the sigmoid colon out through a small umbilical incision, so I don't have to struggle to find the sigmoid. I always do a full thickness biopsy, and we'll talk about that in a few minutes. And while I'm waiting for the frozen section, through the umbilical incision, I'll take the mesentery distally down as low as I can easily get, which through a small umbilical incision in a small child, you can actually get right down to the peritoneal reflection. Some people put a Lone Star or other retractor to visualize the anus. I find that the hooks are kind of traumatic, so I just put those other silk sutures. And then without dilating the anal sphincter too much, I visualize the dentate line and make my mucosal incision about 5 millimeters above the dentate line. And then once I've done that circumferentially, I place these stitches in the mucosa, and I do a very short mucosal dissection, about 1 to 2 centimeters. And then I come through the muscle and get onto the plane on the outside of the rectum, which is this plane here. And then as we're pulling down, I take the vessels as they enter the rectum. And I'm always very, very careful not to twist the bowel as I'm doing that. I then get to the biopsies that I've done, and I divide the bowel and do my anastomosis from below. So this is a transanal suave, but it's a very short cuff, which is different from the way I was doing it at the beginning. And I'll talk a little bit about why I made it shorter to start with. And when I take these bites, I think this is important. I always take a good bite of the underlying muscle, and then my bite of the mucosa is only including mucosa. You have to be very careful to preserve the dentate line and to take very small bites of mucosa so you don't interfere with the dentate line. As we'll talk about later, the dentate line is relatively important in sensation, and I think if you do your anastomosis too low or you take stitches in the dentate line, then you might interfere with that sensation later on. And there are many, many ways to do a transanal pull-through. That's just my way of doing it. This is a slide that shows the outcomes from the transanal pull-through. We put 6 centers together. There was my experience and Louis de la Torre's experience. We published this together. And we included several other centers where we had taught the surgeons there to do this operation. So it was 141 patients. Half of them were less than 1 month of age at the time of their pull-through. And again, we saw a shorter hospital stay than with the open procedure, with a very acceptable complication rate, similar to with an open pull-through. This paper was published in 2003. I think it's safe to say that the transanal and laparoscopic approaches have become the standard most places in the world. I should mention that the reason I use the umbilical incision rather than laparoscopy to do my biopsy and to mobilize the left colon or take down the splenic flexure if necessary is that there are many surgeons in the world that don't have access to neonatal laparoscopy. So this is a way that every surgeon can do this operation transanally in a minimal access way, even if you don't have laparoscopic capacity. So I want to address a few different controversies in the performance of the surgery for Hirschsprung's disease, the transanal pull-through in particular. The first thing is, should this be done in the prone position or the supine position? I showed you the supine position. Well, I'm going to just list the controversies and then I'll go into them one by one. The second one is, do you need to find the histological transition zone before you start that anal dissection? The third is about how long the cuff should be. And the fourth is whether you should do a routine anal dilatation after the pull-through. So the prone versus supine position, this is a picture from Mark Levitt, who always likes to do these in the prone position. And this is the supine position that I showed you. The advantage of the prone position is that most pediatric surgeons are quite comfortable with the prone position because that's how we do our anorectal malformation repairs. And also the visualization is probably a little bit easier and better, especially if you're teaching somebody how to do the operation. The advantage of the supine position is that if you have to do some kind of mobilization inside the abdomen, then you are already in that supine position and you don't have to flip the baby back and forth. So I think either one is fine. You just choose which one makes the most sense to you. The second one is about whether we need to do that preliminary biopsy or whether you can do the whole operation transanally without ever going into the abdomen and do your biopsies as you're pulling the colon down through the anus, which is the way, by the way, that both Louis de la Torre and I started when we started doing transanal pull-throughs. We were not doing the preliminary biopsy. This is just a picture of that umbilical approach that I showed you, but you can also many people do the preliminary biopsy laparoscopically. The reason why I think that there should be a preliminary biopsy before you start the transanal dissection goes back to a study that we did in the early 2000s, where we compared the accuracy of the contrast enema in the neonatal contrast enema in identifying the location of the transition zone. We found that about 11 or 10%, which is the number I gave you before, of newborns with Hirschsprung's disease will not have any transition zone on their contrast study. And about 8% in this study of the infants who had a radiographic transition zone in the rectosigmoid had a much longer aganglionic segment than was suspected based on the contrast enema. And this was important because most of us would not do a primary pull-through on a child with long segment disease. Most of us will do a stoma, wait for the permanent sections, like the case I showed you before we do a total colectomy or a near total colectomy and a pull-through on a child. And if you do your transanal dissection and your biopsies through the anus, you will eventually have a child with long segment disease that you thought had short segment disease. And once you've done that transanal dissection, you're committed. You must do a pull-through. So I think it's important to do a biopsy first in every case. Here are two studies that show that doing a biopsy first, so identifying the pathological transition zone before starting the anal dissection, doesn't change the outcomes of the operation. So this was from that study I mentioned before that we did with Louis de la Torre. The time to feeding, the pain, the post-operative hospital stay were exactly the same whether the surgeon had identified the pathological transition zone first or not. So there's no disadvantage to putting in a laparoscope or making an umbilical incision and doing your biopsy first. This is from a different study that was just my own series. And again, the operating time was the same because you still have to wait for that frozen section, whether you're doing the frozen section from below or whether you're doing it before you start the anal dissection. Their hospital stay was the same, the pain was the same. So again, another study that suggests that there's no downside to doing a biopsy first, and it will protect you from burning your bridges. It will protect you from doing an anal dissection and being committed to doing a pull-through on a baby who might end up having long segment disease. So what about the intraoperative biopsy? So this biopsy that we do to identify the pathological transition zone, it's important to remember that the transition zone is not black and white. It's not like you have normal ganglion cells and then suddenly, boom, you have no ganglion cells. There's usually a few centimeters where the transition zone has too few ganglion cells. And those ganglion cells are not symmetrical, meaning that the transition zone, you could have what look like normal ganglion cells right here, but for a lot of the circumference of that bowel, there are no ganglion cells. So this is something that we learned a little bit later on. You can be fooled if you do your biopsy right here, and then you say, oh, that's normal, divide it right here, and do your pull-through right here. You will only have ganglion cells for part of that circumference, and you will have what we call a transition zone pull-through, which may not function very well. So I think there are three ways to avoid this. The first one is always do a full thickness biopsy. I know many people, and I was taught, many people do just a seromuscular biopsy, especially if you're doing it laparoscopically, because you don't want to make a hole in the bowel and you're worried about spilling stool. But in a seromuscular biopsy, you're only giving the pathologist the myenteric plexus. You're not giving the pathologist the submucosal plexus. So it makes it harder for them on a frozen section to accurately identify presence or absence of ganglion cells. I think it's also important to go some distance above your positive biopsy. So most people are now saying you should go up 5 centimeters to just be sure that you're in completely normal bowel. In the video I showed you, we had 2 biopsies, and so I didn't have to go 5 centimeters above the more proximal one, but I did go 5 centimeters above the more distal one. Some people are saying that you should go 10 or 15 centimeters. I think when you start going that far above, you start sacrificing a significant amount of colon. And I think that does impact on stool frequency and even on continence later on if they don't have as much colon. So I think 5 centimeters is a good rule of thumb to use, but there is still some controversy about that. The other thing that many people are doing now is when they divide the bowel to do the pull-through and they send the specimen to the pathologist, they asked the pathologist to do frozen sections on 4 quadrants of the proximal end of that specimen, just to make sure that there are normal ganglion cells all around the circumference. Now, what about the long cuff versus the short cuff? I switched over from leaving a very long cuff to making a very short cuff because I was finding that there were a significant number of kids that had enterocolitis afterwards, or that required daily dilatation because that longer cuff rolled down and caused obstruction of the pull-through. So this is a study that we performed, but other people have shown the same thing, that with a short cuff, you're less likely to have enterocolitis, you're less likely to have the need for dilatation and these obstructive symptoms. And so as you saw, my Suave cuff is 1 or 2 centimeters long. Many people have actually said, why even do any kind of submucosal dissection? Just do a Swenson operation from below, which leaves no cuff. It's a direct anastomosis between the normal bowel and just above the anal sphincter. The reason why I still do a Suave with a short cuff rather than a Swenson is that I think it protects the urethra in a boy or the vagina in a girl from injury. I think if you do lots and lots of pull-throughs using a Swenson technique, then it's quite safe and it's a perfectly good way to do it. But I do a lot of teaching of trainees, and many of those people are going to go into a practice where they might only do 1 or 2 pull-throughs a year. And I want them to do the safest possible operation. And I have had patients referred to me who have had a Swenson where the surgeon got into the wrong plane and injured the urethra or made a hole in the vagina. So that's why I prefer personally the Suave with a short cuff. But again, a Swenson is perfectly acceptable if you do the operation well. So this is another controversy. Most pediatric surgeons will send the child home, and this is after Hirschsprung surgery and also after anorectal malformation surgery. They'll send the parents home with a dilator and ask them to dilate once or twice a day. And that's how I was taught, but I found the parents hated that, as well as the baby obviously hated it. So I started bringing the child back once a week. So I would, starting at about 2 weeks after the pull-through, I bring the child back once a week, and I do a calibration with a dilator. I feel the anastomosis, make sure that it's not getting too narrow, and I do that for about 6 weeks, once a week, and then the parents don't need to do this at home. And I found the parents were so much happier not having to dilate their own child. When we looked at the outcomes of this, I compared my results to the results of many of my colleagues who were still sending the parents home with a dilator. We had a total of 95 children, 34 of them had Hirschsprungs, the others had anorectal malformations. 65 of them had the standard daily dilatation by the parents, and 30 of them had just the weekly calibration of the anastomosis that I told you about. Of those 33 of them, so about 10%, developed narrowing of the anastomosis while I was calibrating them over those 6 weeks. And if that happened, then I did ask the parents to dilate at home. But it meant that 90% of the patients never needed to be dilated at home by their parents. And when we looked at the outcomes to make sure that this wasn't a harmful thing, we found that there was no significant difference in the risk of strictures, the risk of leaks, or in the Hirschsprung's kids in the risk of enterocolitis. So there's really no downside to the patient, and it saves the parents from the trauma and the child from the trauma of daily dilatations by the parents. So this is something that I feel pretty strongly about, but I do know that even in my own center, after all these years, most of my colleagues still send the the baby home with a dilator to be dilated by their parents. Okay, so the next thing I want to do, how are we doing for time? Yeah, so the next thing I want to do is go through the post-operative problems that these children often have. And this is what I was taught when I was a fellow. If you do a good operation for Hirschsprung's disease, these kids all do great. They don't have any problems. And we now know that that's not true. And the reason we know it is because we're paying more attention to these kids now. We see them more closely in follow-up, and we're just more aware of the problems that these kids can have. There are three basic types of problems. The first one is that they can have persistent obstructive symptoms after their pull-through. The second is that they can have incontinence or soiling. And the third is that they can have enterocolitis. So I'll talk a little bit about each of these and how over the years I've tried to develop a strategy or an approach to each of these problems. There are essentially 5 reasons why a child may have obstructive symptoms. And when I say obstructive symptoms, I'm talking about abdominal distension, constipation, decreased stool frequency, often requiring significant laxatives or enemas. And there are 5 main reasons why this can happen. The first is mechanical obstruction. This is obviously a very tight stricture. This is a child who had a twist of the pull-through at the time of the pull-through. And most of these problems with that are caused by mechanical obstruction, most of these require either significant dilatation or a redo of the pull-through. This is a child who had a Duhamel procedure. And this is one of the problems that you see after a Duhamel sometimes. If the staple line has not gone up high enough, then you end up with a spur anteriorly. And this is the aganglionic rectum. And stool collects in there. And because it's still aganglionic, it can't empty. And over time, it becomes very dilated and pushes on the normally innervated posterior pull-through bowel. You can manage this in 2 ways. Sometimes you can just put a stapler in from below and complete the joining of the 2 walls. If I do this, I always put in a laparoscope from above to make sure that no intestine has snuck down between here. The other thing you can do is either laparoscopically or through a small suprapubic incision, you can just resect the rest of this dilated native rectum. The second cause for obstructive symptoms after a pull-through is persistent aganglionosis or a transition zone pull-through. And usually this is because of an error made by the pathologist at the time of the original pull-through on the frozen section. Or it could be for the reasons that I mentioned before, where you haven't gone proximal enough in your resection and you actually have pulled down the transition zone. And this is a picture that I got from Mark Levitt, where he's showing hypertrophic nerve fibers in a repeat rectal biopsy. So the way that you make the diagnosis of a transition zone pull-through is by repeating the rectal biopsy, biopsying the pull-through bowel again. And even if you see ganglion cells, if you see significant nerve hypertrophy, it suggests that you are still in the transition zone and the child might benefit from a redo pull-through. The third potential cause for obstructive symptoms is a problem with the motility in the bowel that's been pulled through. Even bowel that has normal ganglion cells with no evidence of a transition zone pull-through, sometimes children with Hirschsprung's have abnormal motility in the normal bowel. It's not really normal. Sometimes if you biopsy it, you see something called intestinal neuronal dysplasia, which is abnormalities of the ganglion cells. There's very little agreement among pathologists about what intestinal neuronal dysplasia actually is. And I'm finding that in recent years, there's been much less talk about it. Prem Puri in Ireland is one of the people, and Meyer Rugi in Europe were the people that really popularized this idea. But I think most pathologists that I talk to say it's an extremely rare finding. But it is relatively common to have abnormal motility. So how do you diagnose abnormal motility in the proximal bowel? Well, the simplest way is to do what's called a SITS marker study, where you can chop up an NG tube, or you get little radio opaque markers and put them in a little capsule and have the patient swallow them. And then you do a series of x-rays just following them down. And this is what it looks like initially. And in a normal child who is just, let's say, constipated, they will all collect in the rectum. But in some cases, they will be distributed around the colon, like in this one I showed you before. And in this one, where you see the radio opaque markers, are all in the left side of the colon. So that suggests that the right side of the colon is normal and had normal motility, but the left side of the colon is abnormal with abnormal motility. So this is a relatively simple way of assessing for a dysmotility. Perhaps a better or more quantitative way is using a radionuclide study. This is essentially the same as a radionuclide nuclear medicine gastric emptying study, but the radiologist continues to follow the radionuclide all the way down to the end. And this is probably more quantitative. They can actually measure how much of the tracer is scattered throughout the colon. The person that really popularized this is John Hudson, who was in Melbourne, Australia. And when I went to visit him and he showed me this technique, I brought it back to Toronto, and my nuclear medicine group started doing it. And so this is the way we now screen children with obstructive symptoms who I've already ruled out a mechanical obstruction. I've done a rectal biopsy, repeat rectal biopsy, and I know that they have normal innervation. And the next thing I do is to check for dysmotility with this nuclear medicine study. The most accurate way is using colonic manometry, which is not available in most centers, including in Toronto. We don't have this available. But sometimes I'll send a child to someone who does it. We do have several centers in Canada and certainly in the United States that have the capability to do this. And this is a very sophisticated way of measuring motility in the colon. This is normal. So you see these peristaltic waves. So this is proximal, and then there are sensors all through the colon going from proximal to distal, and you can see this peristaltic wave traveling through the colon. It's a very, very accurate way to measure dysmotility. And this is a child who has an abnormal motility after they're pulled through. See, most of the time there are no waves here. And then you see this one contraction, which is not really a wave because it's happening everywhere at the same time. So it's really, the whole thing is going into spasm. So this is a child who would likely need to have that abnormal bowel resected. And that's really the treatment. If you find dysmotility in a segment of the colon, but the rest of the motility is normal, then that child will benefit from an operation to remove the abnormal bowel and redo the pull-through. Some children have abnormal motility everywhere in their colon and even in their small bowel, and there's no surgery that can help that child. That child needs bowel management. The fourth reason for obstructive symptoms is going back to this rectoanal inhibitory reflex that we talked about before, which is missing in children with Hirschsprung disease. And that lack of relaxation of the internal sphincter, we like to call internal sphincter achalasia. Some people have called this ultra short segment Hirschsprung's disease. I think that's a term that should be abandoned because it's very confusing. When we say Hirschsprung's disease, we really should be talking about a child who has ganglion cells missing for some length of their intestine. If the only thing they have is lack of relaxation of their internal sphincter, then it's not, in my opinion, not Hirschsprung's disease and shouldn't be called ultra short segment Hirschsprung's disease. A better term for that is internal sphincter achalasia. So how do we treat that? Well, When I was training, these children would sometimes have an anal sphincter cutting operation, a myectomy or a sphincterotomy. And a lot of times that actually did improve their obstructive symptoms. But we know that many children with Hirschsprungs also will develop soiling, and it can't help soiling to cut the internal sphincter. So I think the solution for these children, if you have access to it, is Botox, because Botox relaxes the sphincter, but in a reversible way. And most children who have obstructive symptoms because of internal sphincter achalasia generally get better over time. Their sphincter never learns how to relax, but they learn how to overcome the sphincter that's not relaxing. And most kids, by the time they're 4 or 5, will get better and will get rid of those obstructive symptoms. So to use something permanent like a myectomy for a problem which is really temporary never made sense to me. And that's why we started using Botox. And I give nowadays, I started at lower doses, but I now use 100 units, which is basically the whole bottle. And I inject it essentially at the dentate line in 0.1 centimeter injections. So I use 1 cc to reconstitute the Botox, and then I use approximately 0.1 cc circumferentially in 8 different injections around the dentate line, which is where the internal sphincter should be. Some people are using ultrasound to direct the injections, and that's fine, but in my own practice, I haven't found it necessary. Botox works in some children, but it doesn't work in other children. But because there's such a low complication rate, which is really 0, in my experience, and I've done hundreds of injections now, there's no downside. And so I see it as both a diagnostic and a therapeutic procedure. If you give Botox and they get significant improvement, then that tells you that the internal sphincter achalasia is a big part of their symptoms. And if that's the case, then when the Botox wears off in 3 to 6 months, you can keep giving additional injections. And as they get older, most of the time they don't need it anymore by the time they're 4 or 5. If the Botox doesn't work, then I usually try another injection, because sometimes maybe I didn't inject it right, or maybe that lot of Botox was not effective. So I'll usually give one more attempt at an injection of Botox. And if that still doesn't work, then I conclude that the internal sphincter achalasia is not the main reason for that child's obstructive symptoms. And those are the kids, if you had done a myectomy, where you would have done an unnecessary operation that wasn't even going to work. The 5th reason for stool holding behavior, or for obstructive symptoms in these kids, is the kind of behavior, stool holding behavior, that is very common in children who are 3 or 4 or 2 years old who don't have Hirschsprung's disease. Kids with Hirschsprung's can certainly get this kind of behavior, and it's because I think they're more likely to have it because they have this non-relaxing sphincter. They tend to get constipated. They have painful stools, and then they start holding the stool in because they don't want the painful stool, and that vicious cycle gets worse and worse. So sometimes these kids, what they really need is aggressive bowel management, and if you can get over the stool holding behavior, then they actually are fine. This is an algorithm that we developed a few years ago, the APSA Hirschsprung's interest group, and it's published here. So if you have the opportunity, you can go online and pull up this paper. I know a lot of people, including us, have made a copy of it and put it up on the wall in the clinic to help people with their thinking when they see kids who have Hirschsprung's and have obstructive symptoms. And I'll just take you through it very briefly because we've talked about most of this already. The first thing I do is a rectal exam and a contrast enema to rule out a mechanical obstruction like a stricture or a twist or something like that. If there is a stricture, twist, some other mechanical obstruction, then that needs to be dealt with either with dilatation or with a redo operation. If there's no mechanical obstruction, the next step is a rectal biopsy to make sure that the ganglion cells are normal, that there are no hypertrophic nerves. If the child has no ganglion cells on their rectal biopsy, so in other words, if the pull-through has lost ganglion cells or it never had ganglion cells at the beginning, or if there's evidence of a transition zone pull-through, most of the time those kids do best with a redo pull-through. If the rectal biopsy is normal, then the next step in our algorithm is to try Botox. And in fact, usually I do the Botox injection at the same time as I'm doing the rectal biopsy to avoid a second anesthetic. So we'll do the rectal biopsy and give Botox. If the biopsy is normal and the Botox injection shows improvement, so they get better after the Botox, it suggests that the non-relaxing sphincter is a major part of their obstructive symptoms. And we just leave them and repeat the Botox, as I mentioned before, as often as necessary. And most cases like this, by the time they get to be 4 or 5 years old, they will grow out of it and you can stop giving Botox. If the Botox doesn't help, then I go to that motility workup that I mentioned, whether it's a SITS marker study, a nuclear study, or a manometry. And if it's normal, so they have normal motility, then really they need bowel management because this is probably a stool holding problem. If the motility workup shows abnormal motility, but it involves the entire colon, there's really no surgical cure for that problem, and those kids also need bowel management. And the bowel management involves, we won't go into details today, but it can involve laxatives, it can involve stimulant laxatives, stool softeners, it can involve enemas, and in some cases we've used a cecostomy or a MACE procedure in those kids, or in severe cases, sometimes the child needs a stoma. If the motility workup is abnormal, but only for part of the colon, usually it's the left side, like I showed you in that image, then those children will often do well with a resection of the abnormal bowel and a redo pull-through. Okay, what about soiling after a pull-through? Again, it's important to understand what the cause of the soiling is before you are able to treat it. And there are 3 main causes for soiling. The first is that there's a problem with the muscles. The second is that there's a problem with sensation, because you need normal muscles for normal continence and you need normal sensation. And sensation can really be 2 different types of sensation. One is that they don't feel when their neorectum, their pull-through rectum, is full. It can get very distended in some cases and they don't feel that it's full, so they don't know they have to go to the bathroom. And then the second is what I mentioned before about loss of the transitional epithelium where the dentate line is. And then they're just like a child with an anorectal malformation where you've got rectal mucosa anastomosed to skin, and the ability to differentiate stool from gas and the knowledge that you've got stool ready to come out isn't there. So that interferes with continence. And this is an example of an unfortunate child who I saw in consultation who had both of these problems, a very stretched out sphincter. And this is usually, the muscle injury is usually the result of overstretching of the sphincter during the pull-through, sometimes also associated with a previous myectomy or sphincterotomy. So this child has a very loose sphincter, and the anastomosis has been done to the skin, so the dentate line has been lost. This is not a child with an anorectal malformation. This is a child with Hirschsprung's. Now, there are actually probably the majority of children who have soiling after a pull-through actually have normal muscle and normal sensation. And they have what we've termed pseudo-incontinence. And there's 2 different types of pseudo-incontinence. One is a child who's got significant constipation and they have overflow incontinence, and we all are familiar with that. But the other group are the kids with Hirschsprungs who have had their sigmoid or more proximal colon pulled to their anal sphincter, which is what we normally do in a Hirschsprung's operation. But that bowel has more motility than a normal rectum, and they can't handle that peristaltic activity, so they're leaking stool on a regular basis. And it's important to differentiate between these two because the treatment is different. And the easiest way to differentiate is just by doing a contrast enema. So this is a child with constipation and overflow, and this is a child with hypermotility. And you know it's hypermotility and not constipation because the caliber of the pull-through bowel is relatively normal. So this is not a child who's got a big dilated rectum. So how do we manage the soiling? The first thing is you must understand the cause of the problem. And I just went through what those causes can be. If it's true incontinence because of sphincter injury or because of loss of sensation, then most kids do best by giving them a constipating diet and medications to slow the bowel down. We see a lot of kids who are soiling, and the assumption is made, the surgeon just assumes that the child has constipation and gives them a stool softener, usually Miralax or PEG 3350. And those kids are soiling constantly. Their stools are loose. They don't have normal sphincters, or they don't have normal sensation, or both. And they're constantly leaking stool. And the first thing we would do for that child is to stop the stool softener and try and get them a little more on the constipated side so the stool is not leaking out all the time. And then they usually need mechanical emptying of the rectum. And that can be through retrograde enemas, or this is a good population of Hirschsprung's patients to do antegrade enemas with a mace or a cecostomy. And the kids who have normal muscle and normal sensation, again, you have to know whether they've got hypomotility or hypermotility. If they have hypomotility, which is the most common scenario, we give them a high fiber diet. This is where stool softeners can be helpful to make the stool soft enough that the child can evacuate without pain. And we use stimulant laxatives. It's not enough just to use PEG. These kids need stimulant laxatives such as Senna or Bisacodyl to help empty their rectum and keep their rectum empty. In hypermotility, it's a different story. They're already emptying too much, and these are kids where slowing down the bowel is the way to treat them. So we put them on a constipating diet, and we put them on loperamide to help slow things down. And usually that works. Sometimes small volume enemas can also be helpful in these kids. It's also important in all of these kids to have a routine sitting on the toilet, usually after each meal and then before bed. Sometimes they need behavioral therapy from a psychologist, biofeedback training to make them more aware of their sphincter and to help with the normal contraction and relaxation of the sphincter. Biofeedback can be helpful. And if they are a kid who has stool holding behavior, I think that avoiding rectal enemas is helpful because rectal enemas tend to make the stool holding worse. And we have had some kids who have such bad soiling that doesn't respond to any of these techniques. And sometimes giving them a colostomy is the only way to kind of get them back into society. The good news is that many of the kids who have pseudo-incontinence, over time, they also will get better. So if I give a child a colostomy at, let's say, age 2.5, because their bottom is completely broken down, they've just constantly soiling, I don't close that colostomy 6 months later. I will leave that kid until they're at least 5 years old, often older than that, to let them get over that problem before I close the colostomy. And then this is the algorithm from Pediatric Surgery International. Again, write this down. I won't go through this because I think we're getting short on time. Are we getting short on time?
Yes, no, you can continue. Please continue.
Shall I just keep on going? Okay.
Yes.
Because I have a little bit more stuff. So I'll just quickly go through this. So if you have a child with soiling, again, you need to know whether this is true incontinence or pseudo incontinence. Start with a history and physical, rectal exam under anesthesia, and anorectal manometry I find very helpful to tell me whether the sphincter strength is normal or not. If they have normal sensation and normal sphincter function, that means they have good overall potential for bowel control. If they don't, if they have an abnormal sensation and or abnormal sphincter function, then we would call that true incontinence, and they go early on to some kind of bowel management program. If they have the potential for normal control, then we call that pseudo incontinence. And then a contrast enema, you can do colonic manometry if you have it, but the contrast enema, like I showed you, those two pictures, you can differentiate between an obstruction picture and a hypermotility picture. And we already talked about if they have obstruction, then you have to rule out why they have obstruction. And you can go back to those 5 causes of obstructive symptoms that I talked about before, and correct them if there's something to correct. If there's no correctable cause identified, then they need bowel management. And if they still have persistent soiling, then sometimes we go to enema programs or an ostomy. If they have hypermotility, like I said before, then a constipating diet and anti-motility agents are often all they need. But if that persists, then they may need to go to bowel management. So this, again, is available in this article, and I find it's helpful to have it available to you when you're seeing these patients. So I'll go quickly through the last bit of material that I have for you. Enterocolitis, we don't really know what causes enterocolitis, but the most important thing is it's the most common cause of death in children with Hirschsprung disease. And it can occur before a pull-through, but it can also occur after a pull-through. So when we see acute enterocolitis, I think most of you already know this, but we treat it with an NG tube. Irrigation is really the most important part to decrease the bacterial load in the bowel, and broad spectrum antibiotics. There are some kids who keep coming back with recurrent episodes of enterocolitis, and we'll often send those kids home on daily irrigations by the parents. And I've used metronidazole or Flagyl quite liberally in these patients, not just for a few weeks, but in many cases I've used it for many months to try and suppress the enterocolitis. There's some people have talked about probiotics, but there have not been any properly done studies that have shown efficacy for probiotics in Hirschsprung's disease. But I think in individual patients, it may work, so it's worth trying, I think, because there's very little risk. If there is distal obstruction or stasis, if they've got a transition zone pull-through or a stricture or something like that, then clearly you need to treat that, usually with a redo pull-through. And in some kids who have ongoing chronic relapsing enterocolitis, they need a colostomy or an ileostomy. And again, as with the obstructive symptoms and with the soiling, many times the enterocolitis will actually get better over time as long as there's no underlying obstructive problem like a transition zone pull-through. But kids who have ongoing enterocolitis, they usually will improve over time. So if they need a stoma, again, I wouldn't close that stoma until the child is at least 5 years of age. And many of them can have the stoma closed and they do well. The most important thing, and this is a paper from Salt Lake City from many years ago, the most important thing is that the parents and the community physician taking care of the child have to be aware of the risk that enterocolitis poses to that child, the risk of death, and they need to recognize the symptoms of enterocolitis right away, and they need to be trained as to how to do irrigation. So we will not send the kid home from the hospital without teaching the parents how to do irrigations and teaching them about the symptoms of enterocolitis so they can start the irrigations right away. Just a word about total colonic aganglionosis. I could have spent a whole hour on this topic, but I'll just go briefly through it. So this is the contrast enema. There is no transition zone usually in a child with total colonic, other than sometimes in the ileum. And the colon tends to have this question mark kind of appearance. It's a little bit foreshortened. This is what it looks like in real life. This is the ileum, which is dilated, and then you get to this transition zone in the ileum, and then this is the cecum here. So this is total colonic Hirschsprung's disease, which usually also includes a little bit of the ileum, but can include more ileum. We've had some kids where there's up to a third or even a half of the small bowel involved. So what are the management options? Most of these kids, I think, are best served by a laparotomy or laparoscopy as a newborn when they present with biopsies, make the diagnosis, and then give them an ileostomy in the normally innervated ileum. Some kids are best served by just having an ileostomy, and in particular, this is true of kids with trisomy 21 or other conditions, usually genetic conditions, where they may have a developmental delay and they really don't do well with a pull-through. So we do have some kids who have just had a permanent ileostomy. Most people now are recommending a straight ileal pull-through. So removing the colon, bringing the normal bowel, the normal ileum, down to the anus using one of the three operations that we use for shorter segment Hirschsprung's disease. My own preference, and I put a little star here, my own preference is a Duhamel for total colonic Hirschsprung's because it creates a bit of a reservoir at the bottom and I think gives them a lower stool frequency. There are many others who feel that a Soave or a Swenson is a better approach, and this is an ongoing controversy and debate. And there's never really been a good study that shows any difference or any benefit of one technique over the others for total colonic Hirschsprung's. There are two operations that we call a colon patch operation that the idea was to leave more colon behind so that the colon, which was aganglionic, but it is good at absorbing water. So the idea was to do a long anastomosis between the ileum that has motility and the colon that absorbs water. And this is the Martin operation designed by Lester Martin, which is really a long Duhamel operation, leaving the whole left colon in there. Ken Kimura recognized that the right colon is better at water absorption than the left colon. So he designed an operation where he did a side-to-side anastomosis between the ileum and the right colon and brought out an ileostomy. He then, oops, yeah, here. So this is actually this is the first step of the operation, was to resect the transverse and left colon and do a long anastomosis to the right colon because it's better at absorbing water, and then bringing out an ileostomy. The problem here is that the right colon doesn't reach down to the anus, so it required a second operation to divide the blood supply after about 3 to 6 months. So dividing the blood vessels and then doing a pull through of that colon patch and ileum. The problem with both of these operations is that the kids do pretty well at the beginning, but over time, that aganglionic colon just gets more and more dilated, and they end up with a lot of bacterial overgrowth and a lot of chronic enterocolitis. And most of these kids have required a revisional operation later on to remove that colon patch. Even Dr. Martin, before he died, agreed that the Martin operation long-term was not a very good operation. Some people have advocated doing a complete colectomy and doing a J-pouch, just like we would do for somebody with ulcerative colitis. Most of the studies documenting this operation have come from Scandinavia. I think it's also a reasonable approach. My own feeling is that the Duhamel operation accomplishes the same goal. A short Duhamel with a 3 or 4 centimeter residual rectum gives you the same kind of reservoir that a J pouch would give you, but it's a much easier and safer operation than doing a J pouch in a small child. And then just a word about near total intestinal aganglionosis, which is fortunately very rare, where almost the entire intestinal tract has no ganglion cells. Usually there's about 10 or 15 centimeters of jejunum that has ganglion cells and the rest does not. And this is an operation that is probably of historical interest only, where the idea was to do a myectomy of the about 40 or 50 centimeters of aganglionic small bowel, which allowed the normal 10 or 15 centimeters that had peristalsis would push the stool and the enteral contents through this bowel here that had the myectomy, and then you give the child a stoma, and the hope was that it would give them enough absorptive capacity. This operation doesn't work. I did it a few times, and even Maury Ziegler, who first described it, would agree now that there are better options. Most of these kids need long-term TPN. Intestinal lengthening procedures like the Bianchi or the STEP procedure can be very helpful. And some of these children have good results with small bowel transplantation. So the outcomes now, because we're much better at intestinal rehabilitation and we're better at dealing with intestinal failure, especially because of changes in TPN, these kids now have a much better outlook than they used to have. Okay, and then just a couple of things about future directions. There's 2 things that I just wanted to mention. One is the idea of tissue engineering, and the other is the role of large multi-center databases. And the tissue engineering is, the concept is to colonize the aganglionic bowel with ganglion cells after the child is born and has had a diagnosis of Hirschsprung's disease. And there's a lot of research going on now in this, and it has been done in Petri dishes and test tubes. The aganglionic bowel has been colonized with nerve cells from both human and mouse. In vivo, in the rat and mouse models, that people have successfully taken enteric cells, nerve cells, and colonized the bowel in the actual animals. It's unclear what's the best source for those nerve cells, whether it should be progenitor cells that are derived from the central nervous system, or whether embryonic stem cells are more effective. But what we're still not sure about is if you can colonize the bowel with these nerve cells, will they migrate in a normal way? Will they actually function and mediate peristalsis, which is what they're there for? And is it safe to use stem cells, just like with any other stem cell research? Is it safe? And I would also add, is this better than the surgery that we already offer? We do have lots of problems that we spent the last half hour talking about after surgery, but is this going to be a better way of managing it? So there's lots of research being done, and that's something that you can watch with interest, especially the younger members of your association. The other thing is large multi-center databases. That, you know, Hirschsprung's is a rare condition, so there's no single center that has enough cases that we can really answer a lot of these questions and controversies that I've talked about today. This is one of the first large multi-center databases that I was involved in creating. It's called the HDRC, or Hirschsprung Disease Research Collaborative. And what we're doing with this collaborative is collecting patients and their families, collecting the genetic mutation analysis information. So we can, at some point when we have a lot of patients, we can say children with this particular mutation are, let's say, more likely to get enterocolitis, or children with that mutation are more likely to do poorly after a Duhamel operation. So this ability to correlate the genetic mutation with the different kinds of clinical outcomes could be extremely useful for us. And this is something that's being done in cancer management all the time now. Think about NMIC in neuroblastoma. But we're way behind in Hirschsprung's disease. So this is something also to watch as it unfolds. In North America, there's now a thing called the Pediatric Colorectal and Pelvic Learning Consortium, PCPLC, which is a prospective standardized database of now 10 centers, but they're gathering more centers. And basically what they've done is they're all managing kids with Hirschsprung's, and they do it in a standardized way, and they follow the outcome data in a standardized way that they can then pool all of those patients, and they can answer questions like, for example, is it better to do a Duhamel or is it better to do a straight pull-through for total colonic Hirschsprung's? No single center has enough patients to answer that question. But if you have a consortium of hundreds and hundreds of patients with total colonic Hirschsprung's, where the data is being collected in the same way, then it will be possible to answer those questions. And then I also want to mention the parent organization for families of children with Hirschsprung's disease. And the one that I'm involved with is called REACH. There may be other ones in Asia, but REACH is become very active online. You can look them up. It's I think their website is reachhd.org. And they're very helpful at supporting families whose kids have Hirschsprung's. And we are also now involving REACH and other parent organizations in our research projects, asking them what are the research questions that are important to you as a family or you as a person with Hirschsprung's. Because often we find that the families and the patients have different concerns than we have as surgeons. And we design our research studies to answer the questions that are interesting to us, but that might not be the question that's most interesting to a family who has a kid with Hirschsprung's. And one example of that in some of the studies that we've done surveying families is this whole issue of daily dilatation of anastomoses. Where the parents, that is an extremely important research question for families, but for most surgeons, it's not that interesting of a question. So keep your eyes on REACH and other parent organizations. And I'm sorry I went a little bit over. Actually, I went a lot over, but I hope this has been helpful to all of you, and I'm happy to answer any questions.
Okay, thank you, Dr. Langer. It's a very excellent presentation. And now we are going to the Q&A session. We have several panelists, I believe it's 6 panelists, and I want to introduce them. Okay, sorry. Let's begin with Dr. Alex.
While you're doing that, I'm going to leave for about 3 minutes. I just have to go see to something and I'll be right back.
Okay, Dr. Langer. Okay.
And maybe as we're waiting, you would like to announce our next week program. Just
okay, Dr. Siska, you want to make an announcement for the next meeting?
Yeah, probably if you are interested, please come and join us next week on Saturday lecture series. We will have Professor Dr. Simon Kenny, who will be talking about COVID-19 in the pediatric surgery setting. Time will be announced later, but stay tuned to our announcements for further info. So I guess that would be all. Maybe later on, Dr. Gunadi will also re-announce it again.
Okay, while we'll wait for Dr. Langer, maybe if you want to ask some question, you can type in the chat box, and Dr. Francisca and Dr. Gunadi will help you to ask to Dr. Langer. And let me introduce for the panelists for our webinar tonight. There There are 6 panelists, Dr. Alex from Jakarta, and then Dr. Diki is from Bandung, Dr. Purwadi from Surabaya, Dr. Muntadar from Aceh, Dr. Mahmudi from Jogja, and Dr. Harry from Banjarmasin. Okay, for the first panelist is Dr. Alex. Dr. Alex?
Thank you, Emil.
Yes.
Can you hear my voice?
Yes, I can hear you. You can ask Dr. Langer, or you want to ask or comment or share about anything, please.
Okay. Thank you. Thank you, Professor Langer, for a nice presentation. Since my question is, as you know, that Indonesia is a developing country, so it's a small number of hospitals who have creatinine examination for biopsy. So most of our hospital is still use the H&E examination. Sometimes we receive the pathology's result that the ganglion is immature. So what you comment about the ganglion immature, and what we have to do for this? Thank you.
So there are 2 situations in which we see immature ganglion cells. One is in premature babies, and our pathologists are, they're pretty comfortable making the diagnosis of Hirschsprung disease in a premature baby, but the ganglion cells may be premature. So one way to get around that is just, if you have a child who's premature and you think that they might have Hirschsprungs, just wait until they reach term before doing the rectal biopsy, and in the meantime you can manage them with irrigations. If you have a full-term baby or an older child with immature ganglion cells, most of the time that indicates some kind of short segment, not ultra short, I don't like that term like I talked about, but a short segment of aganglionosis, and your biopsy might be actually in a transition zone. There is a condition called hypoganglionosis, where the ganglion cells are fewer than normal and they tend to look immature. But our pathologists don't like making that diagnosis. So I guess if you have a full-term baby or a older child with a diagnosis of immature ganglion cells, it's probably best to repeat the biopsy, try and get maybe a bigger piece. If it was a suction biopsy to start with, then you might want to do a full thickness biopsy, and also get another opinion from a pathologist that maybe has more experience, because you do often have differences of opinions among pathologists, and experience is very important with Hirschsprung's pathology.
Okay. Thank you, Professor Langer.
Okay, thank you, Dr. Alex. And the second panelist is Dr. Diki. Dr. Diki from Bandung. Okay, Dr. Diki. Hello, Dr. Diki, do you want to ask about anything to Dr. Langer? I saw your type about 3 questions in the chat box.
Thank you, Dr. Emil.
Yes.
Thank you, Professor Langer. It's a wonderful presentation. I have 2 questions. As we know that some of our pediatric colleagues in Indonesia doesn't have good pathology support. What do you think? Can we do primary pull-through without just based on only contrast enema? And the second question is, what is a good criteria for pathologic frozen section finding result when we do primary pull-through before anastomosis? Is another description such as immaturity, regularity of ganglion cell, and also that's all. I think is that necessary to ask to the pathologist before we do the colon anastomosis. Thank you very much.
Okay, yeah, thank you for your question, and I very much like your background on your Zoom background. It looks like you're in outer space.
Yeah. Thank you very much.
I like it. So the first question was whether if you don't have a good experienced pathologist, is it possible or safe to do a primary pull-through just based on the appearance of the bowel or the appearance of the contrast study? My own preference would be not to do that, because the data would suggest that at some point, if you do enough of those, you're going to do a pull-through using bowel that doesn't have ganglion cells or that's in the transition zone. So you really have two choices. One is to do a colostomy, do biopsies and a colostomy, and then wait for the permanent sections, which can be done by your pathologist, or if you don't have a pathologist that's experienced, you can send them to somebody else with more experience and get them to read them, and then go back and do your pull-through. But the other thing that some people have done is just do laparoscopy or an umbilical incision or a laparotomy, and just do your biopsies. Do full thickness biopsies. I always like full thickness biopsies for the reasons I mentioned, and put some good stitches in them, and then just drop the bowel back inside and wait for the permanent sections. And then you can go back and do a primary pull-through without the colostomy, as long as you can get the answer on the permanent sections in a reasonable period of time. You know, if it takes a week, then that's probably okay. You can probably manage that child for a week with those biopsies and without a colostomy. If it's going to take a month, that's a little bit maybe harder, and you might want to have done a colostomy. But I do know surgeons in the developing world who are using the technique of just doing the biopsies and getting the final pathology back in a week or so, and then going back in and doing the primary pull-through. Your second question is, what kind of criteria do you use on the frozen section when you're doing the pull-through that tells you that that piece of bowel is adequate to pull down and do your pull-through? And what I want the pathologist to tell me is that there's a normal number of ganglion cells, that they look normal, and that they are present in both the myenteric plexus and the submucosal plexus. And ideally, I want the pathologist to tell me that the nerves also look normal, that there are no hypertrophic nerves. In some centers, they actually measure the diameter of those nerves, and I think 40 microns is the number that's usually used. And if it looks like there are hypertrophic nerves, then you do another biopsy higher up. But I think in most of the studies that have looked at the transition zone and how long the transition zone is, would suggest that even if your pathologist is not highly experienced, if they see what look like normal ganglion cells with normal nerves on the frozen section, and you go 5 centimeters proximal to that and do your anastomosis there, that you will be safe and you will be able to do that pull through without the colostomy.
And what is the good number do you expect?
The number of ganglion cells?
Yeah,
I don't know. There is probably a normal range of numbers of ganglion cells in a high power field. I actually don't know what that number is. I leave that up to my pathologist. But I'm sure that there is there is a normal range there that you could find. You asked me a question I don't know the answer to. That's not fair.
It's okay.
Thank you very much.
Thank you, Dr. Diki. Okay, maybe the next panelist is Dr. Purwadi. Dr. Purwadi, please.
Thank you. Good night, in Surabaya time, Professor Langer. I am Sporwati from Surabaya, East Java. I have two questions. Well, first, in Hirschsprung disease is multi-genetic factorial. Which factor is dominant? Because I have one family with 3 boys Hirschsprung disease. If they want more children, how to prevent it? And second,
Right.
yeah. And second, what is the most difficult experience to treat Hirschsprung disease in Toronto?
So I missed the second question can you repeat the second question?
What is the most difficult experience to treat Hirschsprung disease in Toronto?
Okay. So the risk of having another child with Hirschsprung's disease when you have 3 previous children with Hirschsprung's disease, I think is pretty high. There are numbers that I usually send these families to our clinical genetics department, and they have all those numbers, all the statistics. I don't keep those in my head. But if you have one child with Hirschsprung disease, then the risk of having a second one is relatively low. It's 4 or 5%, maybe. It's a higher risk if the first child has total colonic Hirschsprung's disease. And that makes sense because whatever the gene is and the mutation is in that child seems to have a stronger effect. So it seems to be more likely that it will affect a subsequent child. So it's higher if it's total colonic. It's also higher if the first child with Hirschsprung's is a girl, because Hirschsprung's is less common in girls. As you all know, it's about 4 to 1 more common in boys than in girls. So if your first child is a girl, then it's more likely you'll have subsequent children with Hirschsprung's. And the same if one of the parents has Hirschsprung's. If it's the mother that has Hirschsprung's, then she's more likely to pass that on than if it's the father. So if you have 3 children with Hirschsprung's, especially if it's long segment, I would tell that family that it's a pretty high risk that the 4th child's going to have Hirschsprung. The question about what's the most difficult challenge for us with Hirschsprung disease in Toronto, we're very lucky in Toronto because we have access to a lot of technology. We have excellent anesthesia. We have excellent pathology, which is really key. I think the kids with Hirschsprung's that I've had the most trouble with are, number one, the kids who have near total intestinal Hirschsprung's. Because those kids, it's a completely different thing. It's no longer a surgical problem. It's a intestinal failure problem. And so, you know, those kids go into our intestinal failure program. We're also lucky in Toronto, we have an intestinal failure program, which is a multidisciplinary team, and they do an extremely good job. But the other group that's more common are the kids with developmental delay, and most commonly due to trisomy 21. And those kids have a higher risk, and I'll talk maybe specifically about the Down syndrome kids. Those kids have a higher risk of enterocolitis, and they have a much higher incidence of soiling. And the soiling often doesn't improve as they get older the same way it does in most other children. So I find the kids who have had a pull-through and have Down syndrome are particularly challenging. And perhaps the biggest challenge for them, and you probably have the same issue, is when they get to be 18 and we can't take care of them anymore in our children's hospital. There's nobody out there in the adult world, at least in Toronto, who has much interest in bowel management or much expertise in managing Hirschsprung's in a child with in a young adult with developmental delay. So those patients have a very rough time. And, you know, I often stay involved with the family, but because our hospital rules are we can't take care of them once they're 18, a lot of them have a particularly difficult quality of life as they get older.
Thank you, Professor. Yeah.
Okay, thank you, Dr. Puradi. And we still have 3 panelists and some questions in the chat box. And I have my colleague, Dr. Gunadi and Dr. Francisca to help me. Please, Dr. Gunadi, can you help me with the other panelists?
Thank you, Dr. Emilia. Thank you very much, Dr. Jacob. Nice to meeting you again after we meet in Doha.
Nice to
last
see you
November.
too. I see the
Yeah.
picture in the background there. I think that's
Yeah.
that's the picture from Doha.
Yeah, you remember that. Thank you.
Mm-hmm.
And finally, we have you, although the webinar, but it's very great. We have your lecture, and we have 3 next panelists. The first panelist, Dr. Muntadar, please, if you have any question.
Okay, thank you, Dr. Gunadi. Thank you, Prof. Langer. Thank you, Prof. Langer. I from Aceh. In my hospital, many cases Hirschsprung disease that we use transanal endorectal pull-through like SOAFA, position, prone position, and good result. I want to ask all this time, I made incision 1/2 and 1 centimeter from dentata line. We question if I perform above 1 centimeter from dentata line, it possible. And 2 question, Dr. Prof. Langer, I have diagnosed ultra short segment. Possible I perform biopsy, just biopsy. Some patient good result. Thank you, Prof. Langer.
So thank you for your comment. So when you say ultra short segment Hirschsprung disease, what's the definition of that for you? How do you make that diagnosis?
Yeah, Hirschsprung disease, aganglionosis, intestinal from 2 centimeter from linea dentata.
Right. Yeah. So I think it's reasonable to use the term ultra short segment Hirschsprung disease if you have lack of ganglion cells, no ganglion cells, for a very short length, like 2 centimeters. The problem with the term ultra short segment Hirschsprung disease is that other people use that same term to describe a child with a normal rectal biopsy who has non-relaxation of the internal sphincter, who's missing the rectoanal inhibitory reflex. And that's where the confusion comes, because some people are using ultra short segment Hirschsprung's the way you use it, which I think is reasonable because it is Hirschsprung disease. But other people use the term for not Hirschsprung's disease, for what should be called internal sphincter achalasia. So I think the best way to avoid that confusion is just not to use the term. And for the child who has Hirschsprung's disease with a very short aganglionic segment, we just say it's Hirschsprung's disease with 2 centimeters of aganglionosis. And then everybody knows what you're talking about and it's not confusing.
Yeah, the question, sorry, Prof. Jacob, Dr. Muntadar have a good result only by doing rectal biopsy for that disease. So what do you think?
Well, it depends on how long you follow the patient also. You know, I've seen some children who have had a very short segment of Hirschsprung's, and it's been managed usually not just with a rectal biopsy, but sometimes with a myectomy. And they do pretty well at the beginning, but what I find is as they get older, they have ongoing severe constipation. And I've had to do pull-throughs on some of those kids later on when they got older, and it was, you know, they were requiring enemas, and their quality of life was not very good. But for sure, there are many surgeons out there who would not do a pull-through for a child with a short aganglionic segment of only a few centimeters.
Okay, thank you. How about the first question? You suggest that the transanal mucosectomy starting 0.5 centimeter above dentate line. How about if more than 0.5, let's say 1 or 2 centimeter above dentate line?
Yeah, so if, when I say 0.5 centimeters, I'm talking about in a newborn, in a child who's, you know, a month old, a few weeks old, a month old. I think in an older child, so if I have a 3-year-old, for example, I probably would make that incision at a centimeter, a little bit higher up, which makes sense because the smaller the child, those distances get longer. I think if you have a newborn and you do your anastomosis 2 centimeters from the dentate line, to me, that's leaving too much aganglionic bowel behind. And I think you're more likely to have ongoing obstructive symptoms. It's almost like doing a transition zone pull-through, because you're leaving part at the bottom that is not going to have normal peristalsis.
Okay, okay. Dr. Mudadar, enough?
Thank you, Prof. Langer.
Okay, thank you.
I met you in a nationwide hospital, Prof. Langer.
Yes.
Last year.
Yes, I remember.
Okay.
I can't go there anymore because of COVID. They won't let me go there anymore.
Yeah. Thank you, Prof. Langer.
Okay. Next, Dr. Ahmad Mahmudi, please, if you have any question.
Yes.
Yes.
Oh,
thank you. I am Mahmudi from Sarjito Hospital in Yogyakarta, Central Java, Indonesia. I have interest from in total ganglion Hirschsprung. Thank you for your excellent presentation, Prof. Langer. My next question, I have interested in total ganglion Hirschsprung procedure. I would like to ask, why did you not include the PEPP procedure as one of the procedure for total ganglion? Why did you only mention 2 procedures in your presentation? Swenson, Duhamel, and Schwab procedure. How about the PEPP or the other procedure, Martin procedure? Please you explain condition. Okay.
So I don't know which procedure you're talking about.
Transanal indirectal bulto. Is it possible for total?
Oh, to do.
Yes.
Well, yeah, I think when we do a Swenson or a Soave for total colonic disease, the bottom part, the resection of the rectum, is done using the transanal approach. But I've never been able to do a total colectomy through the anus. You need to do something through the abdomen, and that can either be laparoscopic or through a small umbilical incision or a laparotomy. I don't think you can take down the splenic flexure and the hepatic flexure and the transverse colon only through the anus. If you've been able to do that, then I would like to see the video of that. But the one thing that I didn't really spend much time, or really any time on, because I was worried I would go too long. Of course, I did go too long anyway, but the timing, what's the best timing for surgery in a patient with total colonic disease? So the options are you can do a primary pull-through for total colonic Hirschsprungs. And in the past, there were people that advocated that. Arnie Koran in particular was always very keen on doing a primary pull-through for total colonic Hirschsprungs. Most of us would prefer, I think, to do an ileostomy. And certainly I prefer to do an ileostomy rather than a primary pull-through. And there are two reasons for that. One is that I don't want to remove the entire colon based on frozen sections, because even at my hospital, occasionally there's an error made, and I would not want to remove the entire colon just based on frozen sections. The second reason is that I think when you do a pull-through of the ileum, no matter how you do it, whether you do it a Swenson, a Suave, or a Duhamel, the stool consistency is very loose, and those kids get a lot of perianal excoriation, a lot of breakdown of the skin. And so if you do an ileostomy first, and then you wait until the child is older and the stool has gotten more thick, which usually happens anywhere between 8 months and a year, then I think you can do the pull through then, and you'll have much less problem with skin breakdown on the perineum. Alberto Pena and Mark Levitt for many years were advocating waiting until the child is toilet trained for urine, so 2 or 3 years of age before doing the pull through, so that the child wouldn't be in diapers and could sit on the toilet, and that would also decrease the amount of skin breakdown. But I don't know about Alberto, but I know Mark Levitt has now changed his approach to more like what we talked about before, where you wait until the ileostomy output has gotten thicker, and then you can do the pull through. And that's usually around 8 months to a year. We have, both Mark Levitt and I have seen kids who had a much later pull through, and they develop a lot of sphincter spasm because they've never used their anal sphincter before, and they don't know what to do. And when they feel the stool coming down there, they get a very painful spasm. So that's one of the problems with waiting until they're 2 or 3 years of age. So I don't know if that answered your question, but I thought it would be worth just putting that out there, because that is another controversy that we talk about.
Okay, thank you. Maybe for the last panelist, Dr. Harry, please.
Yeah. Okay. Thank you, Prof, for the great lecture. I come from Banjarmasin, 2 hours from Jakarta. I have 2 patients with severe chronic enterocolitis after full-to procedure. I did the colostomy, now still in colostomy. And what the criteria to reoperation again for this patient, Prof? Thank you.
Right. Yeah, that's a very good question, and I don't know if we have a clear answer. I think the first thing is that you need to make sure there isn't some kind of correctable problem that was causing the enterocolitis, such as a transition zone pull-through, a stricture, a dysmotility, something like that. Basically the same workup that I talked about with obstructive symptoms, because enterocolitis really is part of the obstructive symptoms in many cases. So you need to do a contrast study, a rectal exam, make sure there's no mechanical obstruction. You need to do a repeat biopsy, make sure the ganglion cells are normal. And it's probably worth also checking the motility of that bowel. But if everything looks fine, then my usual approach for a child that I've done a stoma because of ongoing chronic enterocolitis is I wait until they're at least 5 years old. That's what one of my teachers, Dr. Ein, Sigmund Ein, who you probably have heard of, those of you who are a little older, he taught me about this idea of a long-term temporary stoma. So we all want to close these stomas, and the families usually want us to close these stomas as soon as possible. But it's been my experience that you get a better outcome if you wait until the child gets to an age where the enterocolitis usually is starting to get better. And then you're going to be much more likely to be able to close the stoma successfully and not go back to the enterocolitis. The other thing that I've sometimes done is given a Botox injection at the time of the stoma closure, because we do have evidence that using Botox in some kids with ongoing intermittent enterocolitis can decrease the number of hospitalizations for enterocolitis. So that's another approach that you can take when you close the stoma.
Thank you, Prof.
Okay,
You're
thank
welcome.
you. We also have international participants and pediatrician. I return the time to Dr. Francisca. Thank you.
Thank you. We still have a lot of questions, Prof. Langer. I hope you have the time to answer our enthusiastic participants.
Well,
today.
it's only 9 o'clock in the morning here, so I've got lots of time.
It's
I'm
only
with my
9 p.m. here. The night is long. The night is young.
Okay.
I guess.
Yes.
Before that, I would like to say hello to our international participants from Malaysia, from Singapore. I saw Dr. Lo Yi, and then from Pakistan, from Thailand, India, and then from UK, Myanmar, and Brunei. Also, I got a special message from you from Prof. Dayang from Malaysia, saying sorry she cannot attend today, but she sent her warm regards for you.
Great, thank you.
So without further ado, I will start reading the questions, which is the first one. Do prematurity interfere the interpretation of rectal biopsy? Should we perform biopsy at the appropriate age? Or I probably would say, is there any appropriate age, an optimal age for biopsy?
Right. So this is a question that we often debate with our pathologists. There are two problems with doing a rectal biopsy in a premature baby. The first one is just simply the technical problem, especially in a very small baby. If you have a baby that's, let's say, 1 kilogram, and you do a suction biopsy, you're actually taking quite a lot of tissue from their rectum, and I get nervous taking that much tissue from the rectum of a very small baby. And the second is the interpretation of the biopsy because of the immaturity of the ganglion cells. So I think the answer is that it depends on your pathologist and how comfortable they are with interpreting rectal biopsies in premature babies. As I said before, our pathologists have told me that they're comfortable doing this down to about 32 weeks. There's a paper from Columbus, actually, that I don't know if it's been published yet, but they did a study looking at kids 32 weeks to term, and they did not find any difference in the accuracy rate of the rectal biopsy in the premature babies. But they didn't include any that were below 32 weeks. So in our hospital now, if I really am worried about Hirschsprung's disease in a kid who's 32 weeks or older, then we'll go ahead and do a rectal biopsy. But my preference really is to wait until the baby is closer to term, 36 or 37 weeks, because most of those babies aren't going home anyway. They're mostly in the hospital, and you can do irrigations for them and feed them and just wait until they get a little bit bigger so that the biopsy will be safer and your pathologist will have an easier time interpreting the pathology.
Okay, thank you. So you prefer to wait until 36, 37 weeks, right?
Yeah, that's usually my preference. And in the meantime, I do irrigations and feed the babies and just let them get bigger.
Okay, noted. The next question is from pediatrician, Dr. Andi Dharma. He asked, do you have any experience with intrauterine CMV infection inducing colonic stenosis mimicking Hirschsprung disease?
We have seen kids with colonic stenosis that does mimic Hirschsprung's disease. In fact, I was just asked to review a case from somewhere else in Canada just yesterday, where the left colon had multiple narrow areas, in a full-term baby, no evidence of neck or any other reason for that. And it looked a lot like Hirschsprung disease. I'm not aware of a correlation with CMV infection, but that's certainly possible. But I think it brings up the point that the contrast enema is not always accurate, and it's not only what I said before, that 10% of newborns do not have a transition zone, so you can't rule out Hirschsprungs on the contrast enema. But we also have some children who have what looks like a transition zone. They have what looks like Hirschsprungs on their contrast enema, and then you do a rectal biopsy and it's normal. And we published a paper on that, I think back in the early 2000s, documenting that. So I would never do an operation for Hirschsprung disease in a child just based on the contrast enema. I think you really need to do a rectal biopsy to prove the diagnosis.
Sorry. Okay. Thank you. The next question would be from Dr. Kathleen. I have a 3-year-old girl with history of Hirschsprung disease who underwent primary pull-through at 3 months old. Everything went well until around 5 months. She had an episode of acute diarrhea and subsequently on and off enterocolitis. Medical therapy was given along rectal washout. Up to this time, she's in between constipation with soiling and colitis. Contrast enema only showed slightly dilated rectal area. What is your suggestion for this kind of situation?
And the child is now 3 years old, you said?
Yes, now it's 3 years old. The pull-through is 3 months old.
Yeah,
the symptoms started 5 months ago.
Right. So again, I think I go back to the algorithm that I showed you. I would make sure that there's no stricture. It sounds like you've already done that because there's a contrast enema that's been done that doesn't show any narrowing. I would redo the rectal biopsy. I would try some Botox to see whether that helps the symptoms. And if it does, then I would continue to repeat the Botox until the child gets older and gets better. If the Botox doesn't work and the biopsy is normal, then I think starting to look at the child's motility is helpful, doing one of those tests that I showed you. And bowel management in the meantime, because again, most of these kids do tend to get better. Now, if the child's also having a lot of soiling as part of this, then you should do anorectal manometry if you have access to it to make sure that the sphincters are intact, and that and I would do an examination under anesthesia to make sure that the dentate line is intact as well. So the proper treatment of these kinds of patients that have these kinds of problems really requires understanding what the underlying cause of that problem is.
Okay. I was also going to ask about the question regarding rectal manometry. Unfortunately, in most of our cities, we don't have manometry. So do you have any other modalities to help us?
Right. So the manometry gives you several pieces of information. The first piece of information it gives you is the pressure, the internal sphincter pressure. And you can examine a child. I mean, some people say, well, I did a rectal exam and the child felt like the sphincter was very loose. And that picture I showed you of the severe sphincter injury, you know, sometimes just based on the physical exam, you can say, you know, this child's sphincter is probably looser than it should be. Be careful about doing that under anesthesia, though, because under anesthesia, the anal sphincter does relax. So it's very hard to, you know, to make a conclusion about whether the sphincter is okay or not if it's just under anesthesia. So that's the first thing that the manometry tells you. The second thing is it tells you about the rectoanal inhibitory reflex, whether it's present or absent. And that is not useful in evaluating a child who you already know has Hirschsprung's disease and is having problems, because doing surgery for Hirschsprung's doesn't fix that rectoanal inhibitory reflex. Those kids are all going to be missing that reflex. So that the manometry doesn't help you with that. The third thing that manometry can help us with is we blow up a balloon in the rectum and ask the child to tell us when they feel it, right? And you know, if there's a normal range, so if it's if they feel it after 30 or 40 cc's, then you know, okay, well, that child's got normal sensation of a full rectum. If you blow it up to 110 cc's and they still don't feel it, then you can say, well, you know, probably they've got a problem with sensation. And that's something you can do. That particular test you can do without the manometry itself, without measuring sphincters. You can just put a balloon in the rectum and blow it up to, you know, how much you're putting in it, and ask the child when they feel the balloon, and that can give you a sense of whether the sensation is normal or not.
Okay, we will try to do the balloon examination, Prof. Actually, she has another question. She already did the biopsy, the rebiopsy. The result is it's ganglionic.
Yeah, normal.
Yeah,
normal ganglion cells with you need normal ganglion cells with normal nerves as well, right? So no hypertrophic nerves. So if it's normal, then you know that it's not a transition zone pull through, and that's good. You can check that off, and then you have to go on to the rest of the workup. The other thing is that if the main problem is ongoing enterocolitis, and I wasn't sure in this case whether it's more an enterocolitis problem or whether it's more an obstructive symptoms problem, and those two, of course, they overlap, right? Like kids with chronic enterocolitis also usually have obstructive symptoms. But if enterocolitis is the main issue, then I will often put those kids on a long-term course of metronidazole. I mentioned that earlier, but I'm very liberal about using metronidazole in kids who have ongoing enterocolitis. And I find the biggest group that are like that are the kids with total colonic Hirschsprung's disease. And so I've had some kids who are on it for several years, and it tends to suppress the enterocolitis. And most of the kids, as I said, do tend to get better from the enterocolitis as they get older. And age 3, they've still got a couple years to go before I would expect them to get better.
Okay. Hopefully Dr. Kathy's helped with the answer. The next question is from Dr. Lowy. I do 3 biopsies at the level of antimesenteric border and both sides of it near mesenteric border, that is ganglionated. Then I work transanally while waiting for a frozen section. Is there any data that full thickness versus seromuscular biopsy makes a difference in relation to avoiding transitional zone pull-through?
Well, the evidence comes from the pathologists, where there are some cases where the amount of ganglion cells in the submucosal plexus is different from the amount of ganglion cells in the myenteric plexus. So if you only do a seromuscular biopsy, you may see ganglion cells, but in that same spot in the submucosal plexus, there may not be ganglion cells, or there may be too few. So I don't know of any study that compared outcomes in children who had a seromuscular biopsies versus those that had full thickness. But certainly there is a literature in the pathology that shows that the seromuscular and the myenteric plexus may be different in one given location. The other problem is with what you just said is that if you start your transanal dissection while you're waiting for the frozen sections, and then your frozen sections are all aganglionic, and you may end up having one of those cases of long segment disease, and you've already done your transanal dissection, then you're committed to doing a pull through in one stage in a small child, which for the reasons we talked about before, I think is not the best way to go. So what I do instead, and what most of the laparoscopic people do, is while they do the biopsy and then they do the dissection of the mesentery going from above. That way, if you find that you're in a long segment situation, you haven't removed the rectum, you haven't done the transanal dissection, so you could still stop, do an ileostomy or a proximal colostomy, wait for permanent sections, and then wait until the child is older before doing the definitive pull-through.
Okay. Yep. And then the next question is, with a short 1 to 2 centimeters wave cuff, do you still split the cuff posteriorly?
Yeah, that's a good question. I tend not to, because with only 1 or 2 centimeter cuff, I have not seen problems with the cuff causing obstruction. There's just not enough tissue there. So I think if you make a very short cuff, then you don't need to split the cuff.
Okay. And then what is the amount of ganglion found in the normal ganglionic colon? Do you have any experience with the
So that's that question came up earlier, and I don't know what the exact number of ganglion cells per high power field is in the normal. I'm sure that information is available, but I usually leave it up to my pathologist to tell me whether they feel that it's normal or not.
And then, do you have any experience with endoscopic full thickness biopsy?
No, I don't. I know it's been published, so people have done, rather than going in laparoscopically or through an umbilical incision, they use a scope from below to take full thickness biopsies to identify the transition zone. I guess I don't really see the advantage of doing that, because it's pretty minimally invasive to do something laparoscopically or through a small umbilical incision. And some people do a combination. They put in a laparoscope, identify where they want to do their biopsy, and then the laparoscope has gone in through the umbilicus, and then they'll grab the spot they want to biopsy and pull it out through the umbilicus, rather than using the Hager dilator technique that I showed you in the video. But to me, it's that's pretty minimally invasive, and I'm not sure what the advantage would be of the endoscopic approach.
Okay, thank you. And then this is also an interesting question. Botox injection at the dentate line. In what plane would you inject it? Is it submucosal or deeper than that?
I try and go a little bit deeper than that. What I'm trying to do is put it into the sphincter muscle itself. So if you're just submucosal, I'm not sure it's going to get into the muscle. But you know, in a child who's 2 or 3 years old, like most of these kids are, it's only another millimeter or so between submucosal and in the underlying muscle. And that's one of the reasons that I do small volumes, so 0.1 cc, and I inject it in multiple locations. So that way, if I'm not quite in the right place with one of them, the other ones, I am more likely to be in the right place. So, and as I say, some people have used ultrasound to be more accurate, getting it into the muscle, and that seems to work pretty well too.
Okay, I already got a warning that I only have 10 more minutes.
Okay.
What is your opinion regarding skip lesion? Do you have any experience in the patient with skip lesion and Hirschsprung?
So we're always taught that Hirschsprung's disease starts at the anus and extends proximally, but that you don't get skip lesions. But that is not true. I think most of us who see a lot of Hirschsprung disease have seen children who have had skip lesions. The vast majority of them are long segment disease. So they're usually kids with total colonic Hirschsprungs, where there may be islands of ganglion cells at various places in the colon. And the danger, of course, is that when you're doing your biopsies of the colon, if you stop where you get ganglion cells, let's say in the transverse colon, you find some ganglion cells and you say, oh, okay, well, that's the transition zone. You may have found an island of ganglion cells in a colon that otherwise is totally aganglionic. So I do think when I've got a child who I think has long segment disease, I do multiple biopsies, and I don't stop when I get to ganglion cells in the middle of the colon, because you can make a mistake if you do that. So I'll take a biopsy of the cecum. By the way, I think most pediatric surgeons know that it's best not to use the appendix, because the appendix, sometimes they won't find ganglion cells, but it's not total colonic Hirschsprung. So rather than the appendix, I take a biopsy of the cecum, and I usually take a biopsy of the ileum of 5 centimeters or so above, as well as biopsies all through the colon. And I have seen myself some cases where there were some ganglion cells found in the colon in what was otherwise a total colonic Hirschsprung's patient.
Okay, thank you. And then, do you have any recommended technique for redo pull-through?
It depends on what why you're redoing the pull-through.
The first procedure. Oh, why? Okay.
Yeah, so why it's done. And it also depends a little bit on what the first operation was. So when I first started doing a lot of redo pull-throughs, I preferred to use a Duhamel approach, because most of the redos had a Suave as their first operation, and the Suave was usually with a longer cuff, the way we used to do it earlier. So the Duhamel was a very easy way to do that redo. We just had to go behind the cuff in that plane, the Duhamel plane, and it was pretty easy operation. It's a harder operation to do when the first operation was a Swenson or a Duhamel. And I've gradually switched over to more often doing a combined transanal and laparoscopic approach. And I think, so I usually, depending on what I'm doing it for, as I said, so if I think it's a transition zone pull through where it's a very short amount that I'm going to need to remove, then sometimes you can do that just transanally and you don't need to even go in the abdomen, because there's enough bowel there that you can pull down another 5 centimeters and not have tension. If I think I'm going to need to remove more, then I'll start laparoscopically and make sure I do the dissection from above and mobilize the bowel so that it'll come down, and usually do a biopsy as well to make sure I have normal ganglion cells in the bowel I'm planning to bring down. And then I'll turn the patient prone and do the rest of it from below, or I'll just stay in the supine position and do the whole thing supine. So it really depends on the situation, what's the previous pull through, and what's the reason that you're redoing the pull through.
Okay, thank you. And then I will have 2 more questions. Do you have the definition of near total intestinal aganglionosis? How often do you find this condition, and how long is the remaining normal ganglionic power?
So, like most pediatric surgical conditions, Hirschsprung's is a spectrum. And I've seen a few kids, unfortunately, that had total intestinal aganglionosis, including the stomach and the esophagus, and that's just not compatible with life. We've never been able to save those children. The most common near total intestinal aganglionosis that I've seen has been about 10 or 15 centimeters of jejunum that has ganglion cells. and then the rest of the small bowel and the entire colon are aganglionic. And those kids used to do very poorly, you know, in the early days when I first started, because they all required TPN, and they, you know, we tried that operation I briefly showed you, the Ziegler operation, which I did it twice and it didn't work either time. And so you'd have a child with 10 or 15 centimeters of jejunum. They would be on TPN. They would develop liver failure like most kids did in those days, and they would die. Now we almost never lose a child with 15 centimeters of jejunum because the TPN is so much better. And a lot of those kids now can get a little bigger. We allow that proximal bowel to dilate. We've been doing step procedures for them to lengthen the bowel. So a lot of those kids can now survive even without intestinal transplantation, but you really need an experienced high-volume intestinal failure unit, which is multidisciplinary and has a real focus on the detailed management of those kids.
At what age do you usually do your step procedure?
Usually, well, we usually will do it. It's not an age thing. It's how long does it take for that proximal bowel to dilate. So the step procedure works best when the bowel you're doing the step on is very dilated. You can get more length from it. So sometimes we'll just resect the jejunum, put in a gastrostomy, and just leave the jejunum stapled off to promote dilatation of that proximal jejunum. And so usually, you know, when they're 9 months, a year old, is a good time to do the step. But it really depends on the individual child.
Okay, thank you. And then the last one, what is your experience with late diagnosis of Hirschsprung, and would you change your operative management in older children? What she means is that would you prefer to hammer with stapler better in bigger kids, or?
Yeah, and that's a good question, and I don't think there's any I don't think there's any evidence-based answer to that. The first thing, though, is that the kids with a late diagnosis usually have a very dilated rectosigmoid. So a primary pull-through is usually not a good idea. And I usually do a proximal stoma. It's interesting, over the last month or two, I had 2 children who came in the same week. One of them was 15 years old. The other one was, I think, 6 or 7 years old, both with late diagnosis. And I'm suspecting that in Indonesia, you probably see more late diagnosis than we do in Toronto. So the first step is, I think you need to divert these kids. Many of them are malnourished and they've had failure to thrive. The 15-year-old that I just recently saw had a hemoglobin of 6 or 60. So very, very anemic. And so the question is, do you divert them with an ileostomy or do you divert them with a colostomy? I personally prefer a colostomy, usually kind of a descending colon colostomy, if the descending colon is not too dilated. If it's really dilated, then they get technical problems with prolapse and peristomal hernias from the colostomy, so an ileostomy is a better idea in that kid. Once you've done the diversion, then you have to wait a long time, and I usually wait 6 months to a year, and then restudy the child to see whether that rectosigmoid has come down significantly in size. And if it has, then I have had some success doing a transanal approach with laparoscopy from above to do the pull-through if the bowel's not too distended. I think it's a problem to do a transanal pull-through in somebody with a very dilated or thickened rectosigmoid, because I think you end up stretching the muscles too much. So in those cases, I've done Duhamel, which in an older child you can easily do laparoscopically. So again, it depends on the child. I think the important principle is diversion, restudying, and then you make your decision which pull through to do based on how dilated that rectosigmoid is.
Okay, thank you. Thank you, Prof. Langer. We have still several questions that we cannot read because our time is very limited. And I will continue this, Dr. Gunadi, please.
Thank you very much, Dr. Siska. Thank you very much, Professor Jacob Langer, for great lecture and for your time. Please give applause and give to Professor Jacob Langer, everybody. And
thank you very much.
For a short summary, if I may go summary, Hirschsprung is a complex genetic disorder characterized by ganglion cell negative. And then, because of ganglion cell doesn't get there, or ganglion cell got there but don't survive. And then we cannot rely on contrast enema for doing pull-through. It's better to do biopsy first and then wait 1 week. And if we have to wait 1 month, it's better to perform stoma first. And then for intraoperative biopsy, it's better full thickness biopsy. And we suggest resection 5 centimeters above the positive biopsy. And then for quadrant, frozen section should be performed. And previously, a good operation will result in good result. But currently, it's not the case because good operation still have problem after pull-through, such as obstructive symptom pasca pull-through, swelling, and enterocolitis pasca after pull-through. And for management, we have to understand the cause and follow the guidelines. Jacob Langer and American Pediatric Surgical Association already have the guideline in Pediatric Surgery International. And the last not the least, the future direction for the treatment of Hirschsprung consisting of stem cell, but still in vitro in vivo, not in the clinical trial yet. And then the importance of large database for better management of Hirschsprung disease. I think that's the short summary for this great lecture from Professor Jacob Langer. Thank you for the Perbani for the providing this webinar series every Saturday or Sunday. And then we will see in the next Saturday with Professor Simon Kenny from UK. Thank you very much. Once again, give applause to Jacob Langer and Perbani. Assalamualaikum warahmatullahi wabarakatuh.
Thank you to everybody. It's been a real honor for me to spend this time with you. Really appreciate it.
Thank you, Prof.
Thank you, Prof.
Okay. Take care. Everybody stay safe.
Yes.
Thank you.
Thank you.
You too.
Thank you.
Bye-bye.
Terima kasih buat semuanya. Terima kasih Mil, Siska, Bun, makasih.